Good morning, friends. Uh, this is a next subsequent lecture on the management of breast cancer, and I'll be dealing with this entire holistic way of treating breast cancer, covering the part of chemotherapy, medical oncology, and then the part surgery, as well as more detailed description of clinical oncology part, that is radiation oncology treatment and techniques, and a basic conceptual uh, guidance regarding the breast cancer. And then, so let us start. Uh, breast cancer, breast cancer. So epidemiological studies is conducted by the India Today group 2 3 years back, and then it has shown that that's a very high incidence is being there reported in the Punjab state, Haryana, Punjab, Karnataka, and Kerala. These are the two states as Telangana, Andhra Pradesh, West Bengal. So the south portion is really having a very high incidence, and almost 45, more than 40 per lakh women as per the report in 2020. But the current ICMR data says the breast cancer overall India incidence is 10.6 per lakh women in India. So, some sort of clinical guidance regarding the breast lymphatic drainage, because the lymphatic involvement is really brings the breast survival less than 50% survival once the lymph node is involved in any stage. So you see the anterior axillary group of lymph node, deltopectoral lymph node, supraclavicular, paraesternal node, subdiaphragmatic lymphatic plexus. But all of these you must be aware, but this is subdiaphragmatic plexus is very, very important, because this is the way you understand the breast is liver metastasis in breast is a dual metastasis. It's not only by hematogenous, it's also by the subdiaphragmatic lymphatic plexus, which pierces the diaphragm. A plexus lies on the rectus sheath, and then it's involved the liver. So far as the newer concept of the medical oncology regarding the receptor status and then markers, immunohistochemistry, you must know these figures showing the luminal cells, myoepithelial cells. These are the important luminal positive myoepithelial cells. They do have some receptors, uh, so you should know the basic anatomy regarding these receptors and the cells. The luminal cells, they have a different receptors. Myoepithelial cells have a different receptors. So we should know all these things. So that drainage system I have told you regarding the same, the anterior nodes, posterior, lateral, central, supraclavicular, apical nodes, and then it goes to the inner quadrant of a breast, basically going towards the internal memory group of lymph node, paraesternal nodes. But the lower quadrant, lower and inner quadrant of a breast, I've told you, go to the subdiaphragmatic plexus, then enters through the piercing the diaphragm and goes on the superior aspect of the liver plexus, and through that the liver is involved. So this is, this thing we should all know the importance of lower inner quadrant poor prognosis in the breast cancer. So let us go towards the pre-treatment evaluation. First, we'll confirm the diagnosis by FNAC biopsy, the chest X-ray to rule out lung metastasis, ultrasound abdomen and pelvis to rule out metastasis. Mammography is basically not used in the diagnosed case. It's a screening purpose. You must know the importance of a mammography. The opposite breast mammography also required if histology is lobular, because since bilaterality in a lobular carcinoma breast goes as high as 20% in compared to 5% of a ductal carcinoma. And the routine hematological test, bone X-ray, symptomatic patient, bone scan in symptomatic patients. Asymptomatic patients also you can go for a bone scan to rule out the actually the bone metastasis in the breast. You see here the typical picture of a mammogram. Mammogram basically we use two view, mediolateral and craniocaudal view. And here in this picture you see the irregular, homogeneous, high density, opaque lesion. And this is the way of a presentation of breast carcinoma. Had it been the fibroadenoma, it's a smooth circular margin, and then smooth circulars, dense opacity, but the smooth margin is different. It's non-malignant, but it's a irregular punctate calcification. Irregular margin is quite suggestive of a breast carcinoma, and it precisely used in the basically the screening purpose. Screening purpose means it is performed on the healthy females. So let us see the types of like ductal carcinoma in situ. If you encountered in the biopsy, it means the basement membrane is not invaded. So what should we approach? Just go for a lumpectomy and post-op RT to the chest wall in case if a tumor is more than 4 centimeter. But I repeat, there is no axillary irradiation in this case. If a tumor is more larger in size, then mastectomy plus chest wall irradiation, no axillary irradiation. And the lobular carcinoma in situ, bilateral total mastectomy or an ipsilateral total mastectomy with mirror image biopsy. If positive, then total mastectomy of that side also. But it is all being replaced. The current recommendation, there is no surgical treatment required in lobular carcinoma in situ. Only because the only 5 is follow up with estrogen 20 milligram ODO for 5 years. Why it has been so? Because lobular carcinoma in situ rarely become an invasive carcinoma, and bilateral mastectomy is too mutilating at the modern age of retreatment, as per the DeVita. So we will be going through the breast carcinoma early clinical stage 1, stage 2, that is T1, N1, T2, N0, T2, N1, T3, N0. I'll not be going the staging description, so you go through your books for a staging. So the clinical stage 1A and 1A, 2, the sequence of treatment which is required is neoadjuvant chemotherapy, surgery, and radiotherapy, and after the radiotherapy, the hormone treatment as a maintenance. So why in early stage carcinoma chemotherapy? My take is this, that I've seen not rarely that any breast carcinoma patient is dying because of a local recurrence. Most of them dies because of a systemic metastasis. So breast cancer is almost a systemic disease. So according to the NSA-BP protocol B27, the purpose of chemotherapy is to decrease the tumor size up to the such extent that the BCT can be performed. Second advantage of pre-op chemotherapy, to assess the objective response of a type of chemotherapy regime, the patient is highly responsible. And chemotherapy increase the overall 5-year survival from 44% to 88%. So that is the advantage of early breast cancer NSCT. Why recommended, I have already told you, but further supported by the major trial conducted in the 552 patients with a stage 1 to stage 3, not showing apparently any distant metastasis, but 36% patients show microscopic metastasis in bone marrow. That is at present the strongest indication of an NSCT in early stage breast carcinoma. The chemotherapy is more effective in a premenopausal woman because chemotherapy cause, apart from a tumor regression, also causes tumor ovarian ablation in a young woman because of as a chemotoxicity, which provides the added advantage, double the increase the benefit of a premenopausal woman. And other reason is that we don't get a compromise with the dose in premenopausal woman as contrary to postmenopausal woman. So the good amount of a total dose can be given in the premenopausal woman. So that is the advantage of a chemotherapy in premenopausal woman. The surgical management of a breast cancer lies in form of a lumpectomy, quad, that is practiced in the Milan, that is quadrectomy, axillary radiotherapy, or simple mastectomy, radical mastectomy, MRM, and extended radical mastectomy, Hasselt mastectomy, or Patty's mastectomy, that is MRM. Indication and a contraindication of breast conservation therapy. Both the points should be everybody should have in a mind while performing the breast conservation surgery in early breast cancer. At present, the philosophy of what is and what about the axilla lymph node? At present, philosophy, if clinically positive axillary lymph node, treatment is axillary lymph node dissection of level 1 and level 2. Removal of level 3 does not carry any survival advantage, rather increase the morbidity of lymphoedema brachial plexus injury. So it is better to go for a level 1 and level 2 dissection. For clinically negative lymph node, how you do? By axillary lymph node sampling. And clinically negative axillary lymph node, at present recommendation is sentinel lymph node biopsy. If found positive, axillary lymph node dissection is done. If negative, no axillary dissection. So this is a very, very important clinical catch here, that we perform the sentinel lymph node biopsy. If sentinel lymph node biopsy shows the positive axillary lymph node, then go for a axillary lymph node dissection. Otherwise, don't go for axillary lymph node dissection. That is also recommended. So portion of a radiation for the radiation oncologist, after the surgery, minimum lymph node to be removed by a pathologist as per the says as much as possible, but minimum should be 10. If all 10 lymph node is negative, no axillary lymph node irradiation. If 1 to 3 lymph node is positive, axillary radiation has to be there. If histopathology post-op shows and even one lymph node having extracapsular spread, that is the very, very negative sign, so that you must add with the radiotherapy to axilla. And 1 to 3 lymph node found matted and an indication of axillary lymph node irradiation. If a 4 or more lymph node positive, axillary irradiation highly recommended. A fatty lady, the axilla separation is high, chances of less dose to receive to axillary dissection, axillary irradiation, posterior axillary radiation must be given. So what are the condition if unknown axillary status? Radiation to axilla to be given. Fatty patient, high axillary separation, radiation is to be given. And all the patient stage 3 A, B, C, excluding the T3 N0 M0, radiation to the axilla must be given. If overconfident surgeon, lead to disaster. You see here the scar recurrence after the surgery, and then you see the multiple nodule on the scar recurrence on the line of a surgery. It is called true recurrence basically. So it is very difficult to manage at this juncture, and the things are gone out of your hand in case of the scar recurrence is there. So apart from local recurrence, there are different distant metastases like brain, lung, bone, liver, lymph node metastasis. Out of all metastasis, the bone metastasis is supposed to be very good because these patients do survive quite longer after the palliative bone metastasis, bone radiation, and giving a systemic chemotherapy. They do well. But the lung cancer and the liver metastasis, the survival is merely limited up to 1 year. And a brain, that's further it bring down the survival. So early breast cancer, and then now we are switching over the locally advanced breast cancer. The data in developing country is as high as 40 to 50%. In compared to the developed country, you see the data suggests incidence rate is only 2 to 5%. The stage of a locally advanced breast carcinoma is divided into two parts: operable and inoperable. Operable T3N0M0, T3N1M0. And inoperable stage is T4N0M0, T4N1, N2, N3. So we divide in the locally advanced breast carcinoma in two categories. Role of chemotherapy in locally advanced breast cancer. Patient initially presenting with a tumor that required a mastectomy can be potentially downstage to allow BCT, but actually it is not true. The BCT has a very, very unique indications. So it is not a concept, no longer exists that you downstage the tumor and then do the surgery, this thing. Because if a tumor is already T3, the stage, the treatment is already planned regarding this thing, locally advanced. So you have to go for MRM, not less than that. The response to the NSCT is a strong prognostic factor for outcome of a disease. Inoperable tumor can be converted into operable. I mean, I'm not agreed about this. The report says after the NSCT, if surgery is performed, percentage of axillary lymph node is positivity significantly decreases. That is the quite convincible statement. I'm satisfied with that. So locally advanced breast cancer is typical recommendation according to the receptor status, 4-cycle neoadjuvant chemotherapy, anterior or induction chemotherapy, and go for a response assessment. If you good response, then go for a surgery followed with the radiotherapy, and then again leftover cycle of a chemotherapy and followed with a hormone treatment according to the ERPR status. But if it a poor response in this thing, then they change the chemotherapy regime. Second, go for a receptor status investigation, and then after the chemotherapy, go for MRM and then RT and maintenance chemotherapy and a hormone treatment according to the receptor status, and follow up the patient. So now this is the very important for a radiation oncologist resident, the radiotherapy planning in breast cancer. One must be aware of a pre-op staging of a tumor. The post-op histopathology should be look for the tumor status of excised tumor margin, estrogen progesterone receptor status, HER2 new status, and a lymph node sampling to know how many lymph nodes are positive. So far as external beam radiotherapy is concerned, two types of planning techniques we use: whole breast technique, then block technique, and the local regional radiotherapy or 5-field technique. The whole breast technique, we use only two tangential field, and a computerized planning is required for optimum delivery, like a treatment planning system. The disadvantage of this kind of planning is the less dose to the SCF area, high dose to the lung tissues, and do not involve internal memory chain. So it was now obsolete, giving this the whole breast radiotherapy technique. Used for the breast BCT patient and LABC after induction chemotherapy, was now obsolete just for the academic purpose. I am telling you the whole breast technique. This is, you see here the whole breast technique, and then you see here the separate internal memory field is not used here. That I'll be telling you that what are the serious implications of not including the separate internal memory field if you are taking this thing. And then second, you see the supraclavicular field and medial and lateral tangential field in the one. There is no separate axillary field used here. So a lot of flaws here in the whole breast technique. Now, loco-regional radiotherapy of 5-field technique, you see here, the separate internal memory field is used, SCF axilla is used, field. Again, there is a problem in this, that you are field. What is the mistake here is that the scar is taken into the 2 field, which is not required. You should include the scar in 1 field, a tangential field, because if you are taking in a 2 field, it's quite chances of a recurrence is there. So what we treat in the breast 5-field technique, the chest wall, axilla, SCF, and a separate internal memory chain, and humeral head to be protected by circular seal, because site of active hemopoiesis, and also as the post radiotherapy, the avascular necrosis of the head of the humerus is there, and also as well as lead to the joint fixity, frozen shoulder in the later part of her life. So posterior axillary field recommendation when axilla is heavily involved, fatty patient, SCF dose unable to deliver adequate dose to the axilla as a supplementary or boost dose, so that as a supplementary or boost dose at the end of the treatment, coming end of the treatment, 10 to 15 fractions, this axillary field irradiation is done. Internal memory field traditionally included earlier, but now under the question. So you see here the same thing which I wanted to mention you. The scar in the is covered in the figure B in the 2 fields, but in the second figure C, you see the scar in the SCF area is beautifully covered, and the internal memory field, medial and lateral tangential field. So this is the thing which we need to understand, so that the scar should be covered into the 1 field. Sometimes the clinical situations comes that there's a large pendulous breast and BCT is performed, you have to go for radiotherapy, then you can use a thermoplastic cast to immobilize the breast, and inclined breast board also, because these pendulous breast sag anteriorly, superiorly, I mean, so they're creating a problem to the SCF dose. So inclined breastbone is important. It causes the beam of tangential beam and a mismatch of tangential field with SCF field can be minimized by using the inclined breastboard. And entire radiotherapy planning, they first ask the patient to lie supine, arms abducted, involved side, and the head turned opposite side. So make the sternocleidomastoid taut, and then you go for a marking of a field. Technically speaking, if you see here what figure A and what about the figure B, that you see in the figure, upper figure, is quite a high dose of radiation going into the lung. And then what disaster is done, that the internal memory field is included into the tangential field, and the entire dose is delivered this. But if you use the separate internal memory field, you see the difference. The lung tissue is very less portion of lung is involved for the radiotherapy by using a separate field. So that is the clinical catch here to remember. The same thing is here, the thick chest wall patient. You see the internal memory field in a figure A, and then a tangential field separately used, but there is a cold spot lying here. But if a patient is thin, you see there is very less amount of the cold spot pertained here. And then the figure C indicates if you include the internal memory field and the tangential field in the one field, then you see such a high volume of a lung get irradiated. This is the tangential field blocks which we used. The half beam block, and then use of half beam block rule out the high lung dose, and then also block decrease the penumbra and dose inhomogeneity at the junction. So I told you about the SCF field. We can for a tangential field, we use the inclined breastboard, thermoplastic cast, and divergence of beam. Beam is directed through the superiorly to the oblique way, so that the chances of high dose area to the beam junction from SCF junction lower border and the upper border of a tangential field can be avoided. The furthermore, Harvard Center has developed the vertical hanging wedge block. We use this block. So this block is used in order to make the beam sharper, as well as the extra radiation to the divergence of the radiation beam going towards the medial tangential field can be avoided. So you see here why the half beam block is used in the radiotherapy planning. Why not we can just open the field, see the figure, like rather than opening the DE field, such a wider field, we can open only KE field. If you open this amount of a KE region, but the basic philosophy of a center which is lying in this figure at the point A will go up to the point P, which we don't want. We want in every situation center to be remain there at A. So also see the beam inhomogeneity at the both the borders of the tangential field. And why? Because the breast, the tissues are thin there, and in the center the tissues are thick. So avoid this problem with the open field. We use the wedge of a 15-degree wedge. See in this figure, if we use a wedge, it compensates the tissue gap, so the dose is more homogeneous in the breast. Entire philosophy is to give the dose to the chest wall. We don't go dose to the below the chest wall. So an intact breast, if the BCT is performed uh, and the chest wall, we want to irradiate. But and also the beam energy which is used, the 6 MV Linac is more than enough for the breast cancer treatment for radiation purpose. But there are some clinical situation like patient is having a very wide separation, more than 20 centimeter tangential field separation. There, there are chances that it's high dose to the lung. Uh, Separation, the high dose to the lung, and lung goes as well as the, chest wall irradiation basic purpose get fails. So, if we separation of a tangential field is more than 20 centimeter, the only one indication of a high energy using 15 MV Linac when this separation of a tangential field is more than 22 centimeter. That you should remember. There's also very, very important things. The simulation, you see the central lung distance and a maximum heart distance. Here you see the MHD. The maximum heart distance is the width of the heart in the tangential field at its maximum level. And the central lung distance should be not more than 2.5 centimeter. If it is more than 2.5 centimeter, there are chances of high dose to the lung. So we keep it at, if it is 2.5 or 2, it is quite good. Otherwise, the percentage of a dose to the lung is getting increased. This is basically the posterior axillary irradiation, which is used in the last phase of the radiotherapy planning, because whatever the dose delivered by the SCF we delivered, suppose 50 gray, it does not the axilla receive the 50 gray, because the SCF you are planning that giving a dose at the depth of 3 centimeter, and if you see this expression of axilla is almost coming to the depth is 6 centimeter or 7 centimeter in the thick fatty lady. So what are the difference of a dose? Suppose 39 or 36 gray gone through the SCF. We subtract that dose by 50 gray, so the leftover dose like 14 gray or 12 gray to be given at the end sessions of the radiotherapy by field technique to the separate posterior axillary field. The border of a posterior axillary field, the medial border is spine of scapula, lateral border lies bisect the head of the humerus, and then upper border runs parallel to the clavicle. So that separate axillary field is, the border is like that. Role of interstitial implant in a breast carcinoma to give boost to the site of excision following the lumpectomy. After the external beam radiotherapy in form of a scar boost treatment for a small local recurrence after the BCT. So usually we give 10 gray in 2 fractions of a scar boost treatment in order to prevent the scar recurrence in case of basically in the when there are poor prognostic factors associated with the disease of breast carcinoma locally advanced. Now, some part of a medical oncology like a hormone treatment, women with a ER/PR receptor positive status, estrogen 20 milligram OD reduce the annual risk of recurrence by 40%. So tamoxifen equally effective in a premenopausal and a postmenopausal woman, those who are ERPR positive. The hormone treatment is more efficient in the postmenopausal. Why? Because usually the data says the ERPR positive status in a postmenopausal woman is found to be 64% cases. And ERPR positive status seen only for 45% cases in a premenopausal woman. And so the more postmenopausal woman carry a more almost 64% cases they do have a ERPR positive status. And that is why the hormone treatment is more effective in case of a postmenopausal woman. But the tamoxifen giving something you should be aware of the side effects. With the tamoxifen called endometrial hyperplasia, the patient, those who are in the long-term use of with tamoxifen, you go ultrasound done and then get in this thing endometrial hyperplasia is there, thick endometrium there, and then though the chances is only 1%. The 2% risk of a thromboembolism, that is a very, very most important complication. So the patient with a history of, this medical history against the coagulation profile or some problem with this, we should consult the medical oncologist or hematologist oncologist regarding the treatment of tamoxifen treatment. Tamoxifen also causes an postmenopausal woman hot flashes, and because of introstrogenic effect. So we used selective serotonin reuptake inhibitor venlafaxine for that purpose. If you see the status of ERPR status, that response of tamoxifen is 78%, but ERPR is positive status. Second best response is found in the 45% if ER negative and PR positive. But if ER, PR both positive, tamoxifen response rate is 78%. If ER positive and PR negative, the response rate comes to 35%. But a patient is having ER, PR negative, do also responds to tamoxifen 15%. Why? Why this happens? Because the ER-PR status is a quantitative assessment of a receptor status on a tissue. If suppose 10 femmole estrogen is less than that, then it is reported as a negative. If a 5 femmole progesterone is less on the tissue sent for a receptor, it is considered reported negative. So it does not say that it's all the tissue do not having a ERPR. So still they have a ERPR. So that's why 15% response present. So you see here is the ER negative and a PR positive response rate is 45%. But those who are having a ER positive and PR negative, the response is 35%. This is called bystander effect. This is a diversity and they're known as a bystander effect. The second important drug for a hormone treatment use aromatase inhibitor, usually used mainly in a postmenopausal woman, those who have a known contraindication to tamoxifen treatment, history of thromboembolism, deep vein thrombosis. So we don't give tamoxifen, we use aromatase inhibitor. If a tumor shows HER2 negative status, they do not respond to tamoxifen but do have some response to aromatase inhibitor. But what are the disadvantages of using aromatase inhibitor compared to tamoxifen? Aromatase inhibitor associated with the increased rate of bone loss. The osteoporosis is very high, thus high risk of bone fracture is there. So in all cases, those who you want to go for aromatase inhibitor, bone density index must be carried out prior to the start of treatment. The two drugs are more commonly used, letrozole and estradiol. The most common dilemma in the post-op cases of CA, what we should do if histopathology show margin positive, and that's a clinical situation. We must know if a post-op histopathology of a breast cancer, send for a radiotherapist for radiotherapy planning, and the margin is positive. You resend the patient to the surgeon for resurgical excision of a margin, and then you start the radiotherapy. Otherwise, the scar recurrence chances is very high. Thank you very much.